Ladies and gentlemen, we move on to the next oration of WCCPCI 2016. That's Professor M. Khalilullah oration. This year, this oration is being conferred on Dr.Pawan Sharma. He is currently a senior consultant cardiologist and director of nuclear medicine at St. Mark's Hospital at Mountain Star Heart Center at St. Mark's, Salt Lake City, Utah, United States of America. This morning, for the next 13 minutes, he would be deliberating on the assessment of clinical risk of stroke in atrial fibrillation, CHADS versus CHADS vascular scores, etc. And I'd like to request the chairpersons to kindly stay on. Joining them would be Dr. Satish Gupta. Dr. Pawan Sharma, please. Thank you.
This is a great honor to give the oration for one of my favorite cardiologists, Dr. Khalilullah, who has been a champion and a pioneer in the field of cardiology in India. Atrial fibrillation is a very common rhythm problem, not only in India or USA, but all over the world. And the biggest complication we worry about is stroke. And there are other complications also, but stroke because of atrial fibrillation has the worst prognosis compared to stroke because of some other reason other than atrial fibrillation. So the most recent guidelines came out in 2014, and they are kind of in line with European guidelines also. But remember, the guidelines are not scripture. They are not hard and fast rules. They are just guidelines. Every atrial fibrillation patient is a custom job, so you have to do whatever is necessary depending on that particular patient. They are big, long guidelines, but the main thing is they describe new agents, new anticoagulation. There is a big role of anticoagulation for stroke prevention in atrial fibrillation. The role of aspirin is going down in the current guidelines. And the ablation has gone up. And there are some risk calculators, how to calculate the risk of stroke in these patients. The definitions are already given here, but main thing is paroxysmal atrial fibrillation is less than 7 days, persistent is more than 7 days, long-standing, lasting more than 12 months, and permanent is when the decision is made that AFib is not going to go away. The term lone AFib is briefly mentioned in the new guidelines, but there is a big push that maybe we should drop this terminology. Chronic atrial fibrillation has not been mentioned, even though we always talk about chronic AFib, but that is not mentioned in the new guidelines. The other thing is the new guidelines recommend that CHADS VAS score should be used rather than the old CHADS 2 score for risk assessment of the stroke. There are several bleeding scores, but HAS-BLED has been recommended as the score which should be used to assess the risk of bleeding. There has been a mention of the NOACs, or some people call it DOACs, in the new guidelines. There is no recommendation that which medicine you should prefer. All they say is if somebody is stable and doing fine on warfarin, there is no need to change, but otherwise please consider these agents in these people, especially if there is a lot of variation in the INR and there is a struggle in maintaining the patient INR on warfarin. Try to think of NOACs. So it is not the type of atrial fibrillation, but it is the CHAD-VAS score which should guide whether the person needs anticoagulation or not. Bridging with heparin or low molecular weight heparin is not usually recommended for atrial fibrillation except if the person has a mechanical valve. But you have to assess the risk and benefits. At the same time, it is also recommended in the new guideline that if the CHAD-VAS score is 2 or more and patient undergoes PCI, try to use the bare metal stent, and then you use warfarin with Plavix and try to avoid the aspirin if possible in order to minimize the risk of bleeding. Aspirin has gone down in the new guidelines because there are hardly any studies actually about aspirin. So aspirin is basically going away. About rate control, they say that if you can use the oral agents, try to use that, and they have sort of relaxed the guidelines for rate control. They're saying at rest the heart rate should be less than 80, and otherwise if person is asymptomatic and has a normal LV function, up to 110 heart rate is okay. And then the AV node ablation and CRT pacing have been moved to 2A category. This is a unique entity, hypertrophic obstructive cardiomyopathy. what the new guidelines say, irrespective of the CHA2DS2-VASc score, if a person develops atrial fibrillation and has hypertrophic obstructive cardiomyopathy, you should use anticoagulation in these patients, irrespective of what the CHA2DS2-VASc score is. The complication and success rate is reported to be same in AFib patient or AFib patient with hypertrophic obstructive cardiomyopathy. And the common medication used are amiodarone, calcium channel blocker, disopyramide, or beta blockers. So these are the new guidelines basically, which says class 1 indication for ablation is paroxysmal atrial fibrillation refractory to one drug, and persistent atrial fibrillation refractory to one drug has been moved to class 2A. So these are just the main thing is what I want to show is that class 3 indication, which is ablation should not be performed with the sole intent of obviating the need for anticoagulation, meaning that don't do ablation just if patient says, I don't want to take Coumadin or NOACs or any of those things. That doesn't mean you do ablation. So that's the main thing. So there is a big stress on stroke prevention. There's a big role of oral anticoagulants. Now, this paper came out just 2 months ago, in August 2016. This is a study from Israel. Basically, what they did was they looked at more than 1 million patients, and all of them were in sinus rhythm. They did not have a diagnosis of atrial fibrillation. And they found that even though a person has no diagnosis of atrial fibrillation, have sinus rhythm, but as the CHA2DS2 score or CHA2DS2-VASc score goes up, the risk of developing atrial fibrillation goes up. So even if we are talking about stroke prevention in AFib, but this paper says that even if somebody is sinus rhythm, but they have a high CHA2DS2-VASc or CHA2DS2 score, they have a higher risk of developing atrial fibrillation. And that's what it shows. They use this incidence density rate. So as the CHA2DS2 score or CHA2DS2-VASc score goes up, even if they are in sinus rhythm, the chances of them developing atrial fibrillation are higher. Now talking about prediction of stroke risk with CHA2DS2 score. Well, in general, it has been shown that the stroke rate increases by approximately 2% with each point increase in the CHA2DS2 score. So for example, if the CHA2DS2 score is 0, the risk of stroke is still not 0, it is 1.9%. And when you reach the maximum CHA2DS2 score of 6, the risk of stroke goes up to 18.2%. The only problem is CHA2DS2 score is good for high-risk patients, and low-risk patients sometimes are eliminated. So this is just the CHA2DS2 score, which you know all of these, that the risk goes from 1.9% to 18.2%. So CHA2DS2 score, CHA2DS2-VASc score is recommended in the new guidelines. The only thing is in CHA2DS2-VASc score, the gender has been included, so women cannot have a score of 0. There have been some controversy whether women should be included into the risk category or not, but some studies have shown that is why CHA2DS2-VASc score includes women as a high-risk category. This is the CHA2DS2-VASc score, what factors are looked into: congestive heart failure, hypertension, age, gender, diabetes, stroke, all those things. And as you see, as the CHA2DS2-VASc score goes up, the risk of stroke goes up. There are a lot of bleeding risk scores available: Wright score, hemorrhage 2 scores, Atria score, but the most commonly recommended is HAS-BLED score. And that includes hypertension, renal function, liver functions, stroke, bleeding risk, labile INR, age, and use of certain drugs and alcohol abuse. So these are the scoring for HAS-BLED score. The score of more than 3 indicates high risk of bleeding. Now the main thing I want to say is, just because somebody has a high HAS-BLED score, that is not a contraindication for any form of anticoagulant. You still have to recommend anticoagulation. You just have to assess the patient and explain to them and do more frequent follow-ups, avoid other drugs which can increase the risk of bleeding, those kind of things. But HAS-BLED score is the only one which has been validated in the NOACs and in patients taking aspirin and patients who have not been treated at all. So that is why HAS-BLED score has been included in the guidelines. I already mentioned this point that it is not a contraindication not to use anticoagulant. At the same time, fall risk, we talk about fall risk all the time, but fall risk itself is not a reason not to give anticoagulation. Now, recently there was a paper published in October 2015 which compared ATRIA, this is a new ATRIA score, with CHADS-2 and CHAD-VAS score. The main thing about CHADS-2 score, it's very simple to identify high-risk patients, and the limitation of CHADS-2 score is it does not increase certain other age factors like 65 to 74, vascular disease, gender, those things are not included in CHADS-2 score. CHADS-VAS score is better in identifying low-risk patients who do not need anticoagulation unnecessarily. So therefore, both US and European guidelines have included CHAD-VAS score as the preferred method. This was the paper I was talking about. Basically, they use C statistics. If it is more than 0.5, that means it is significant score than the placebo. And the other thing what they did was they compared ATRIA score, CHADS-2 score, and CHAD-VAS score, and they, even though they calculate all those three scores in every patient, they used a net reclassification index and tried to put them together and see which has a higher risk. And what they found, and they defined low risk, moderate risk, and high risk, which is the cutoff is less than 1% is low risk, 1 to 2% is moderate risk of stroke, and more than 2% is high risk of stroke. The other thing in the ATRIA risk was they included a lot of age categories. That's the main difference, and they did include GFR, which was not included in the previous studies. So what they found was, basically they compared all those three scores, and what this is, I've already shown this, so I'll skip through this. What they found that the ATRIA score, the low risk patient were 40% and the high risk patient were 49%, whereas in the CHADS-VAS score, there was only 6.6% people in the low risk category, whereas 82% in the high category. So they think that ATRIA score defines better, but this study has been criticized pretty badly right now. It is debated because they included patients. This was a study from England actually. They looked at patients who were AFib but not anticoagulated, and the follow-up was only less than a year. So that is why it is being looked at. And this was published after the guidelines. So we don't know which way the guidelines will go, but right now they're recommending CHAD-VAS score should be used for risk stratification. The female gender is still a debatable issue. European guidelines do not consider female gender as a risk factor, especially if the woman is less than 65 years, they have a low risk of stroke. So in conclusion, the current guidelines basically say that it is highly emphasized the use of oral anticoagulants if the CHAD-VAS score is 1 or more than that. The other advantage is we still need a better risk score because they are very complicated. It's hard to remember. We still need a better identification of the risk scores where we don't have to calculate, and it's easy to find out which patient should be anticoagulated and which patient should not be. Thank you very much.
Thank you, Dr. Sharma. Ladies and gentlemen, please stay on. I request our chairman, Dr. Chopra, to kindly, along with other dignitaries, to honor him.
This was a very, very nice paper.
HK.
And we just heard that this particular entity has to be always considered in atrial fibrillation management. It is the CHAD score and the hemorrhage score, and the margin is very narrow. Less than 2 or more than 2, we can create a havoc. I think it's very, very important. And the data which is shown by Pawan is a fantastic data, and I think we are working on it, and he contributed a paper for our AF update, which is a very, very powerful paper. I think this is in a joint paper from the United States, going to be published in our atrial fibrillation. You want to say something, Kapoor?
Yeah. See, the CHAD score or the CHAD S2 score, the ATRIA score, they have excluded, they have not considered, which is an absolute indication for anticoagulation, is the presence of LA appendage a clot. Why is that not been included? I mean, if there is an LA clot,
See,
if there is a left atrial clot.
Come here. Pawan, he is an echo guy. And he says LA appendage and LAA is very, very important.
Yes.
Predictor of a thromboembolism. Why not? They are included as a criteria.
I on purpose took that slide out because Watchman device has recently been approved. When the guidelines were written in 2014, at that time Watchman device was not approved by FDA in the United States. But now Watchman device has been approved and it is indicated for people who are not candidate for anticoagulation. So good point.
No, I'm just saying that even if they are candidates for anticoagulation, but if they have got evidence of LA appendage clot,
Yes.
and the CHAD-S2 score is less than 2,
The point
they are
very well-
still candidates
No,
for
I think the point very well taken on Dr. Kapoor, because that's a real clinical problem.
See, that's the
And
problem.
just listen to me, Pawan. It's a very important point he's raising. We see a lot of echoes, and a lot of patients have a low flow state. A lot of them have a LA clot. A lot of them have a LA appendage clot. That CAT score is normal, for example. That does not mean they should not be given anticoagulants. So he says, in the criteria of inclusion, this point should also be considered. And we agree with you, what you pointed out, that when giving a Watchman device, this point, so somebody more has to work on it. I think it's a very important suggestion, very important suggestion. You're also right that whatever studies have been done so far, they never thought of it.
That's what I was trying to say, that it's a very important factor. That we still need a better score than what we have. Even if it's spontaneous contrast in echo, left atrium, that is a very high risk factor for a stroke. It should be included. You're absolutely right.
Mr.
I'll
Chairman,
request
that's all
Satish to
the
please join
time
me,
that we have.
along with Poonam, P.P. Mohanan, and Jagia. And Dr. Agarwal, please also come. Kapoor, come forward. Your suggestion is very well taken, no conflict with Pawan. I'll request Krishnam Raju and Dr. K.K. Kapoor. Please come forward, K.K. Kapoor. Medallion for Pawan. Beautiful presentation. God bless you, Pawan. He's come all the way from US to give this important, prestigious oration in the name of a very famous person, Professor M. Khalilullah. Thank you very much,
Heartiest
Pawan. God bless you.
congratulations, Dr. Pawan Sharma. Ladies and gentlemen,